Well, guys, I think we're going to get going. We'll start with the intros and getting this moving so we can get to the presentation and any of your questions afterwards. So just to start us off, I'm Judy Thompson. I'm the Director of Clinical Education at Ava, and we're very happy you're here at Ivy League Learning. Along with me, every other week, I have the privilege of working with Dr. Kristen Jacobs, who is our chairperson for this endeavor. And before I turn it over to Kristen, I do want to acknowledge Tanya Heim, the president of Ava, is honoring us here with her presence as well. So thanks, Tanya, for being here, and everybody else that joined us. And right at 4:30 for me, 7:30 for many of you on the East Coast, I'm going to turn it over to Dr. Jacobs for the introduction.
Awesome. Thank you, Judy. I am very honored to introduce Beth Sladowski as our speaker tonight. And Beth has been a nurse for over 26 years, and she's worked in all kinds of fields in critical care, rapid response, EMS, vascular access, trauma. So that this topic, I think, is near and dear to her heart. She currently works for Medline with EMS systems all over the country. So this is her one of her favorite topics. So welcome, Beth.
Okay. Thank you so much. Excited to be here. So thank you so much for the invite, Kristen and Judy. As she said, it's very casual. I'm just going to share my screen with a PowerPoint. I just have 15 slides to kind of go through, so that way we can, I'm very visual, and I hope y'all are too, but not you, James. You just stay driving. So, and if you have any questions, by all means, feel free to ask, and I don't mind stopping. So Intraosseous, I've spoken at Ava for a couple years in regards to Intraosseous. I asked a lot of vascular access specialists, like, raise your hand in the room if you guys are comfortable with placing IOs. And a lot of people said no. Like probably 10% of the room was like, no, that's a rep response, that's ER, that's trauma. And so that's why it's so passionate to me that vascular access specialists have IO as one of their tools in their toolkit, because it's all about the right line at the right time. Situations where it should be used. So I was a very big proponent for IO, especially working in ER, working in trauma, knowing that sometimes vascular access was very difficult to get. But, you know, it was probably like 2015, I believe it was, where, you know, we had central lines in every single crash cart. Code was called. We're on our knees trying to palpate, blind sticking the AC, hoping we're getting something. The doctor's jumping on the femoral. And so one day an IO rep had come around and said, you know what, I think you should look at this. And so I said, okay. So I tried it back, had it in my pocket. And not kidding, 20 minutes later, and I had used IOs around the hospital, but it was one that was typically in the ICU or in my vascular office or in ER. So it wasn't something I had readily available on me. This device I did. And sure enough, the code chimes go off and it said to the lobby. And typically if it's a lobby, it's just, you know, low sugar, hypotension, that type of thing, near syncopal. Oh no, this guy was full VFib, arrest, fully closed and seizing. So I look at my ER doc and I pull out this device and I'm like, well, and so the IO was his only access. We took him directly to cath lab, obviously shocking him, doing compressions, pushing our meds through the IO. And he was a 99% LAD and a 99% circ. So he was the widowmaker. He walked out 2 days later, no deficits. That was my like wake up moment that everybody should be confident and utilize IOs. So situations where they should be used, obviously CPR, rapid sequence intubation if you can't get vascular access, sepsis if you can't get another line in time and you're risking their mental health. I always say anoxia starts in at 2 minutes, anoxia some reversible, like irreversible at 4. By the time you're up to 8 and 9, you're brain dead. And so we don't, you know, especially like after Judy and I took an IO, I'm like, you better IO my mom in a heartbeat if she if she goes down. So what are the benefits? 10 seconds. On the average, 10 to 20 seconds for a novice even. Non-collapsible vein, right? So the bones, they don't collapse, they don't dilate. So they're always available. Much easier to hit than a collapsed vein because they're in cardiogenic shock. It's a reliable bridge to access, large volume infusions based on insertion site, high flow rates, very low infection rate, and first attempt success rate greater than 98%. Different insertion sites for adults and pediatrics. Right now on the adult, the distal femur is not FDA approved, but it is for pediatrics. And apparently for the FDA for distal femur, it is 21 years and younger. And that was new to me because PALS is pretty much done at 8 years old. So I was like, okay, that was something new when I was speaking to Teleflex in regards to that. So you have the proximal humerus, the distal femur, proximal tibia, and distal tibia. So anything that's closest to the heart is typically your first go-to just because of time, volume. So you would go further away from the heart if you're unable to get that access for whatever reason. So common devices, you have EasyIO, which is the driver. That is the maroon with the needle set. That one is like the #1 in the market because it's been out, I think, since like 1990. Judy probably knows the exact date. And so that one is very familiar on the market. It's a driver, you connect it, you look at your needle depth and you insert it. This one here, if you guys can see my cursor, this is the big, it was the first generation spring loaded. Not very well loved in America. I'm just gonna say that. I called it a big piece of equipment. However, I did really love this IO spring loaded because they kind of made it the second generation. So everything they didn't like about the first one, they came out with the second one. Sam recently in the last few years came out with a manual IO. So instead of relying on a driver, you can manually place it in. And then more of our traditional IOs are over here that are manual based. So there's kind of a plethora out there. BD had an IO that was pulled that's supposed to be coming back, I think in 2024 as well, that is similar to the EasyIO. This is Judy getting an IO. So, you know, everyone always like thinks, you know, it's barbaric, last ditch effort. Even on the Vascular Access page on Facebook, we'll see people note like, if I can't get this line, I'm going to have to put an IO in. So it's really about changing your thinking of what is best for that patient in that moment. I love her music. You guys hear the music this time?
Wow. I would give that a 2 to a 3 max.
That's it?
Yeah. Honestly, it's a 2 to 3. I can still feel it right now. Feels like pressure.
Yeah.
Nice work.
2 seconds.
So that's what I want to know what it feels like coming out.
Okay. Wow, look at that.
Wow.
Wow, that's amazing.
Don't pull back because it's going to hurt.
Yeah, just pull it. Yep.
That doesn't hurt either. That is so bizarre. You're going to have to grunt a little bit.
Hold it by the syringe.
Where?
Yeah, just use the
You're
syringe.
doing good.
Yeah, just take your time.
You're doing fine. It doesn't hurt.
Yeah.
It doesn't hurt?
Yeah.
No, I feel pressure. It doesn't hurt.
Yeah.
Don't
Keep
unscrew
pulling.
it. It's not a screw. You're just going to pull
Keep
hard.
pulling.
And grunt. There you go.
That's it.
Should.
That's it.
You just feel more pressure than I was expecting.
right here.
Yeah.
Goes.
Oh, perfect. Wow. Oh,
That
yeah. Sure.
was
That's how it
really
does.
not bad. I am absolutely shocked.
Oh my God, Judy.
So
that nurse that was her very first time. So Judy walked her through that as a champ. And ironically, when I was speaking for Ava, I think it was in Vegas, she happened to be in the audience that day. And she was like, that was my very first IO. So that was incredible. She added that. I'm sure she's probably a pro at IOs now, but you can see even as a novice how easy that was to insert. This is the spring-loaded device, the Neo.
After locating.
Oh, how do I go back? There we go. Got a little touchy. I was trying to fast forward it a little bit just because I know we're a little short on time.
Clean the site using proper technique.
I was a little nervous because it was the doctor's first time of putting an IO in as well.
Remove the neo from the package, place over the site in proper position, using the non-firing hand to secure it to the patient while gripping on the textured dots. Rotate to the operational position, squeeze down with the palm, and then squeeze, do not pull, to deploy the neo.
So that was it. Honestly, very same thing as Judy. It felt like a 2 to a 3, much less than someone putting in an IV of like an 18 gauge or drawing blood, fishing around. It's the pressure that is painful because it doesn't dilate, but it also, it doesn't collapse, but it doesn't also dilate. So when you're pushing a lot of pressure through, if they're alert, you definitely need to use some lidocaine with this. This is just a cadaver showing how fast the IOs can get into the body. Nice thing about that, your bones don't move like veins do, so much easier. The flow rates, humerus, 3 seconds to the heart, 5 to 9 liters an hour, which is awesome. I've had septic patients where I put an IO in them, gave them the volume, avoided putting a central line in, was able to utilize a peripheral IV later because now, we actually had vascular access back. They were no longer hypotensive and hypovolemic and never needed pressors. Tibia is typically in history been the go-to just because it's a flatter base and people are more comfortable with it. But we're finding that with the tibia, it's probably 1 liter an hour and 40 to 60 seconds to the heart. So only in situations if they're seizing during COVID, if it was more of a viral illness that you didn't want to be near the face, you would start with the tibia and until you could protect the airway. On me, if I'm pushing Narcan, I will not use the humerus because it's a bad day when you get thrown up on and the first thing they're going to do is throw their hands up in the air and you'll dislodge it. But other than that, humerus is definitely a preferred site for a lot of places. So you just want to check with your protocol. This is fluoroscopy of a cadaver. So you can see how fast it gets into the great vessels without even the heart beating. So that's pretty impressive. This is a cadaver again, and you can see how fast
This is a flexible humerus insertion. I am now flushing, and you will see the subclavian vein engorge.
So it's kind of instantaneous. The minute you're pushing through that bone, you're right into the subclavian. People often ask, is an IO a central access? No. So by definition, a central access is something that terminates in the great vessels. IOs are technically peripheral, even though they get into the central access very fast. And I love this picture to show why. So yes, it is going into the main veins, but you can see all the collateral veins that the bone feeds. So that's why you can utilize an IO just like you could utilize an IV. So any indication for an IV you can use, but you wouldn't want to sustain patients on pressors because all of these little vessels can then become damaged as well. So really using it as a bridge to access. So in code blues, y'all know it, everybody comes running in. The difficulties and risks for CVC placement are magnified. We know now with NHSN or if they have inadvertent arterial cannulation, anything like that, the hospital is now being penalized. The patient's at higher risk for poor outcomes. The room, you're higher risk for needle sticks, things like that. So with using an IO, you can definitely save time and money. So you're placing the right line at the right time. And then if they make it through the code, that's our hope, right? So we're not going to lose them because we're trying to gain access. Then we can bridge to a central line if need be, sterilely. So emergent venous access. I always think this is amazing. So we looked at the 10 to 20 seconds that it takes for an IO on average. The average emergent CVC is 9 to 15 minutes. So they're like brain dead between 8 and 10. First success attempt rate, low as 38%. increase of inadvertent arterial cannulation, pneumo, DVT, CLABSI, should also be removed within 24 hours once it's placed. So not very good vein preservation if we're putting it in just to take it out to put another one in. And the HA does not recommend inserting a CVC as their go-to for first access. Peripheral IVs, if you have, you know, an AC that you can get an 18 gauge or a 20 gauge or 16, anything that's large bore, by all means, absolutely. But don't waste your time on trying, minutes go by. On adult patients, PALS, they say if the patient is in respiratory or pulmonary, any type of cardiopulmonary arrest, that you go directly to IO. So yes, we still want to go IV if it's able, but you don't want to take too much time. On average, peripheral IVs take 2.9 attempts, and that's not in a critical situation. Ultrasound averages 4 to 4 minutes with an 85% success rate. Now, obviously that varies from vascular access specialists to maybe ER inserters, but it can take up for two minutes for medications to reach the central circulation. So if you're like in the palm of that hand, that's between 10 and 20 cc's per minute. As you go up the arm and the AC, things like that, you get up to 300 to 500 per minute. And as you know, with IO, you can get it there in 3 seconds. Risk of infiltration, extravasation, arterial, and then again, it has to be removed within 24 hours if it was placed emergently. So why not go IO if you can't get an easy peripheral IV? IO contraindications: infection at the insertion site, fracture or trauma to the selected bone, orthopedic procedure. So it doesn't go through titanium. I did try it once in a CT code. I put it in because in my defense, it was a good zipper. It was like little, so I didn't see like the direct down one. So it went ting. So I was like, okay, next leg. So I went to the next leg because he was in CT and the legs were first for me to go after. And that being said, if you miss, you just go to the next site. If you have one proximal humerus, but this patient's still hypotensive, you're needing medications that might not be compatible, go for more sites. There's no reason that you shouldn't be able to place one more, like another IO if need be. The big thing is IO in the last 48 hours in the same bone. So unfortunately, I did have a hospital called me and it had a 3-year-old and they had put an IO in. They didn't get a blood return. They were worried about insertion. So they took the IO out of the leg. Then they put a second IO in. They did not get a blood return. They were worried about insertion, like being there. So they took that one out. Third time around, they got the blood return. They pushed the meds and the baby died. So unfortunately, the baby died because they took the path of least resistance, right? So that bone doesn't dilate. So as you put that pressure in, it's kind of like a hole in a water line or a hose. So you only want one insertion site for 48 hours. Unable to locate landmarks in a court of law, if you're utilizing a device, you need to know indications, contraindications, and landmarks. History of bone disease is considered a relative contraindication. Some IO manufacturers don't have it as a contraindication and some do. So you always just want to check with your manufacturer. And I tried to talk really fast so you guys have time, and I am respectful of your time.
That was great. Thank you so much.
Yeah.
I did not know that you actually had a big place. That was awesome.
Oh, thank you. It was the Neo.
Oh, Neo, yeah. Sorry.
First generation, no. Second generation, I was all
okay. Did you let them flush it?
I did have them aspirate it. We happened to be, I had to ask the CEO of that company that morning because I was in the Houston office and we were meeting with clients later that day. So I wore the dress that had the hole in it. And I said, well, can I? And he's like, are you serious? I was like, yeah, absolutely. Like, it was because I was doing the gain confidence for Ava and you had done it. So I was like, well, we already have one with a drop. We need to show one with a spring loaded so that people aren't so afraid that it's so painful or that we're going to hurt somebody, because, you know, we're always fearful of doing something new that we might hurt them.
Sure.
So I wanted to change that view. And he's like, what's the worst thing that could happen? I'm like, air embolism, death. But I'm like, I'll be fine. But the doc was funny because he had done it on cadavers. And I was like, all right, you have one shot. Let's do this. Because, you know, they're recording. But he did great. Right. Went in simple like a novice, just like you. So I thought
Absolutely. No, good job.
Thanks.
Anybody, I didn't even look. Do we have any questions on this yet? I could just talk to her about this for ages.
I know, it's such a good topic.
It's a great topic. I am such an advocate for IO that obviously, I mean, if I went to the point of having one placed. James.
Yeah, over the years, I've been trying to promote IOs over and over again, but always get feedback from the doctor. It's not a good. Well, they'll get osteo. Less effective IO.
Have you been, what can you do to get past the bureaucracy of, to let you do this? Is that what your question?
Yeah.
Beth?
Sure. So a lot of times doctors do have that false sense, or they've actually overplaced it. So a lot of times, especially as a resident, they'll just like throw them the driver or throw them a spring load and say, put it in. And so once they have a failure, they're a little bit more hesitant, or they think that it doesn't work. So typically what I do is I have that discussion, like, can you explain to me why you're not, an advocate for IO? What has happened? How many times have you used it? Who trained you? And then also evidence-based practice, right? So we're all about evidence-based practice. So up to date, which is what the doctors a lot of times utilize throughout hospital systems, is very much an advocate of IO and shows that osteomyelitis is less than 0.06%. And in the studies that it even had an infection was, I want to say like in the 1980s, where they left it in for more than 24 hours. So even though some manufacturers allow it up to 48 in emergent cases when you can't get something else, still the recommendations are to pull it within 24. And that is the reason why. In 2023, Springer just published, they did a large retro study, and it showed that IO is definitely preferred if they can't get easy IV. So just kind of, I would just do like a PubMed search and then go and have a conversation with the physicians for outcomes. And as far as they're concerned, they're not getting poked in a code. And then as far as your hospital is concerned, they're not wasting money. They throw away central lines out of every code cart every 2 years. A lot of these IOs have a 3 to 5 shelf life. So the likelihood of that with decreased infection, with decreased needle sticks, it's just like a win-win all around.
I know down in, oh gosh, Johns Hopkins, I want to say Johns Hopkins, they've gotten rid of all their central lines out of their code carts. They only have IOs now, which is fantastic. So
that's awesome.
Isn't that amazing?
Yes, I was lucky enough to be on the consortium with Dr. Chopra. So in 2014, we removed all central lines from our crash carts and put in IOs, 2 IOs, because you always want a backup, or right. 2 needles, whatever it is, you always want to have a backup. And then University of Michigan followed in 2015. And so we were like the little cub hospitals. So I was really happy to work with Dr. Chopra.
That's fabulous. That's fabulous.
They did.
I think that's the way to go. I have seen some god-awful procedures done during codes, and unsuccessful, I might add. And all these docs going in, not all these docs, I don't want to be disparaging. I've seen some docs go in blind into the fem and not even understanding that the femoral artery overlies that vein about 30% of the time. So they're causing giant hematomas and unsuccessful at that. And then time is life. You can't wait that long. In 3 seconds, you get an IO in and are pushing meds. Sorry, I get excited.
We have some raised hands.
Yay!
I think Mickey was the first one. So Mickey, do you want to give us your question?
Sure. Great presentation. I'm not too bright, so I got kind of lost on the kid story, the baby story. So you said, and I understand, you can have more than 1 IO at a time, but they put in IOs and took them out, and that was the problem.
Great question. I'm glad you asked that. I should clarify. any IO in the same bone in 48 hours is a complete contraindication, because it takes 48 hours for that bone, for that fibrin to actually sit and seal. So what happens is if you have a hole like in your arm and then they put a second hole in, because of the pressure that it takes to overcome to push the medicine, it just goes out the other hole. However, you have, you know, depending on which IO you're using, you can have up to 2, 4, 6, 8 sites to go after. So when I'm saying more than one, like I had a 16-year-old that came in with sickle cell, and he was coding, very acidotic. I had 2 IOs here. I had 2 proximal humerus. I had 2 in the leg, and then I put an 18 gauge in, because kids aren't dead until they're warm and dead, and we were fighting for his life. So I wasn't going to waste time on getting volume in. So you can use different sites, just not the same site for 48 hours.
I guess I didn't realize that they had used the same site, and so.
Sorry about that. Yes.
Well, duh. Okay. All right. Thank you very much.
Yes.
Thanks, Mickey. Jacqueline.
And then, Jacqueline.
Yeah, so I work in pediatrics, and when I think of like our hospital, we service like a lot of like NICU and like infants. I guess like what is the youngest age that you would put in an IO for?
That's a great question. It kind of matters on the manufacturer and what your protocols say. So typically the manufacturer says anything for 3 kilos and greater or 4 kilos and greater. IOs in like very neonate patients, they do in studies comparative to UVCs, they have been easily over penetrated. So if you're in the hospital and you have someone experienced with a UVC over an IO, as long as that, you know, that cord is still readily available, on average, it takes about 40 more seconds to get the UVC line per the studies, but that way you still have a little bit more stable access. Now, if you're down in the ER and they don't know how to do a UVC line, but you know, it's still viable, then I would place that IO and then just make sure that you bridge that access very quickly.
Yeah, that's a tough one because the bones are so soft. It's very easy to go through and through the medullary space, and then you have a infiltration or extravasation on the back end. So
yeah.
Well, that's what I was kind of wondering, if like you have to pad their legs in a certain way to drill, because like with babies and like younger kids, they're, you know, they don't have all their muscles and tendons yet, so their skin just kind of moves all over. So any tips or tricks for like positioning for those types of patients if they're younger?
Yeah, absolutely. You always want to stabilize. So you brought up a great point of putting like rolled towels underneath their legs, and they naturally frogger out. So that's great, so that you're always coming in on that leg at a 90-degree angle. And they found, like, you know, with the pediatric one, depending on the device you use. So like Neo per se, it has a step needle, so it helps prevent in the infants to over penetrate. So it goes from a 18 gauge to a 14 gauge. So it's really hard for you to over penetrate that small bone. And then Easy IO has the distal femur, especially in infants. So it's a little bit larger of a bone. You can actually feel the drop, less likely to over penetrate it. But I always stabilize it and then allow it to, you know, have their little frogger legs out. So you're right at the 90 degrees, and then roll up towels and then stabilize it after. I always have 2 people on any infant, so that one is stabilizing and the other one is connecting and making sure that they tape off, because the last thing you want to do is put it and then you have this heavy tubing and now you just pulled it out. So great question.
Thank you.
thank you. And we didn't, I know your presentation was great and it was quick because we asked you to be quick, but we didn't even address what to do on those conscious patients. And you mentioned sickle cell, because I had this, not because, but you mentioned sickle cell. I had a patient that I got to know really well. She's a sickle celler, and she was venous depleted. She didn't have anything left this is a few years back. And she would message me on Facebook and say, I'm coming to the hospital, I'm in a crisis. And we got to the point where I couldn't get anything out of her anymore. I couldn't get another central line. I put 31 central lines in her between PICs, axillary, IJs, FEMs. And she started asking for IO. And we do the lidocaine protocol. So there's you know, you have to sometimes get creative with some of these patients.
Yeah.
Well,
Yeah, I've had sickle cell, and I'm from Detroit. So I have a lot of IV drug abusers that would just straight up say, I have nothing. I even use the veins between my toes. I would like an IO. So, you know, for both patients, you know, having the ability to give an IO, and as you all saw, the insertion is not the painful part. It's especially like in the tibia, it's the pressure of the volume. So following your institutional protocols and priming the extension tubing and making sure that you let it dwell in that space is huge. So the last thing you would do is put it in and then slam some lidocaine, because that would not be beneficial. So, you know, literally 0.2, just very, very slow, let it dwell in that bone for at least 90 seconds. And then you can repeat it again. So kids, I think it's been a minute and I don't have that slide put all up, but I think it's like 0.2 kilos to 0.5, 2%. For adults, and typically the tubing between EZ-IO Neo is between 0.8 ml and 1 ml tubing. So a lot of times if they're conscious, I'll have some, like while I'm putting in, I have someone else prime that ready to go, and I'll use a 3-way stopcock. So that way I can have my lidocaine go through, and then I can flush after I let it dwell in the space.
absolutely. Yeah, so that it's not just for the patient trying to die. It's for
No.
Definitely.
No, I had one with an INR of 18, and patient had an atrial clot, and so we couldn't reverse the INR of 18, and so we couldn't get a peripheral line. The patient was clamped down, so we did an IO. And in those events where it is not emergent, you should be as close to sterile as you can. You should have a mask, you should have a sterile field, you should clean with chloropleth, allow it to dry fully, you know, sterile gloves. So that way you're decreasing the risk of any type of infection towards that patient, especially sickle cell patients that, you know, they're already compromised, and even IVDH patients that are compromised. So if it's not emergent and you have a minute, take the time to utilize that to be as much aseptic and sterile as you can.
Absolutely.
Beth, what about patients that are obese patients?
Obese patients, if they're emergent, IO all the way. A lot of obese patients have great vessels for ultrasound guided. So, you know, you want to pick the right size for the patient. Neo does it differently because their needle isn't penetrated. So if this is my like forearm here, if you're pushing in the Neo, because the needle isn't penetrated, your proximity to the bone is closer before you actually penetrate it. EZ-IO has different needles so that you can actually, and same with SAM-IO, they'll have the little 5 millimeter marks where you're going to actually touch the bone. Make sure you still have at least 5 millimeters, so that ensures that that needle is long enough for that patient. If you stick a needle in and it does not have that 5 millimeters, and you take that out, as long as you didn't drill it or push into the bone, that is not considered an attempt for the 48 hours. You can take that one out. But if the minute you tried for a spring loaded or you tried with the driver, that's considered an attempt. So yes, they do make them BD before it went off the market. They had one at 55 millimeters. So they're getting larger in sizing, just to accommodate what's going on in the United States.
You know, it's surprising too that even with someone that's morbidly obese, when they're laying back, a lot of the adipose goes down. The person that you can't get sometimes is the bodybuilder that, you know, they lay back and their muscles are still bounding right here. But you get someone that's 500-600 pounds, when they lay back, the adipose tissue kind of folds onto the bed a little bit, and you can actually feel their humerus. Have you found that?
Oh, absolutely. Excellent point. I always tease. So I work with Border Patrol and Special Forces for IO. So I always tease them because, you know, they're very muscular, and they will do the sternal IO a lot, especially if their limbs are missing and they need the sternal, but as well as if they can't get to the sternal, but they can get to the leg easier, or they have trauma up here to get to down there. I tease them. I'm like, well, you're muscle, but y'all miss leg day. But honestly, it's just because they don't have any muscle on the interlateral aspect of the tibia. So it's kind of a funny thing. But like you said, I had Memphis call me and they're like, you're never going to believe this. I had this patient was 700-pound septic. They couldn't tell if it was AFib, RVR, but it was like over 220. They could not get access. But like you said, patient was back. They had to remove the doors to get the patient out, to get the patient to the hospital. They put a proximal humerus IO in. It stayed the whole way, and they even got all their lab work off of it, which does bring up another point. Proximal humerus I love because it's very vascular, but don't send anything that down there that spins on a machine without labeling it IO blood, because if you clog up lab's machine, they frown upon that apparently. They found that out. But they can utilize that blood. You just need to let them know ahead of time.
Absolutely. Do we have any other questions? I feel, Beth and I think we could chat about this all day and just, it's so much fun. But
well, I'm down to only one extra Kristen Jacobs in here. So
how'd that happen?
There you go. There were 3 at one point in time.
So. I love it. Well, since y'all are vascular access and I just appreciate your time. If you guys don't already have a protocol, Medline, we have like standard protocols that you guys can add. So the wheel's already been invented. I'm sure Teleflex, all different places do have standard protocols that you can add to your own. Reaching out to the manufacturer, we're happy to help come in and do education. The one thing I will say is education should be like train how you play. So find that you do an IO casually, like, you know, in a room, on a mannequin or on a table. But then after you've had it, then I recommend y'all racing against each other. So I usually have teams of 2, and then I say go, and they have to say the steps out loud, find the location, insert the line, because that's what happens in a stressful situation like a code. Everybody's looking at you, they're waiting for you, and you're feeling all this pressure, and then you're like, wait, what? So I always say, and then anytime you bring out an IO, you should practice on it every single day for 30 days. Just to get that memory coordination. And then I highly recommend, I believe it's May is Stop the Bleed month. So that's what I really recommend, bringing out those IOs during that month, having it readily available, and then retraining yourself, because that one day that you do your checkoff isn't adequate to stay efficient unless you're using it on a regular basis, regardless of what kind you use.
I think the hardest one too is the first. Well, I know the hardest one's the first. It's daunting for sure. But
the first time I used the spring loaded, I was like, yes. And then I used to carry it in my pocket, and my boss is like, you're so sick and wrong. And I was like, no, you don't understand. I am never going to be on my knees while a doctor's doing CPR and I'm not trying to poke myself in a blind situation when I don't have an ultrasound on me, you know? So I was really excited for the opportunity to utilize different IOs. And we, in the hospital I used to work in, they still utilize 2 different IOs. So, you know, whatever works for your system, go for it. Reach out to, you know, all of the people that are here to help you, because we'd love to help you.
Absolutely. And guys, if you're interested and like, I think it was, I forgot our friend, Mark, that said he's had a hard time to try to get it in his protocol, let us know and we'll see what we can do to help you. That's one of the benefits of being with Ava as well. Well, with that, Beth, this was great. It was super fun. I appreciate you so much. Kristen, as always, thanks for being here. And Sheila, the whole gang, everybody that's been each and every week for the most part, we appreciate you. And thanks for being here. And we'll see you in 2 weeks.
All right. Take care, everybody.
Thank you. Bye.
Bye, everyone. Bye.